this important critical issue that we feel is relevant in youth sports and especially with alpine ski racing. Eldora Mountain Ski and Snowboard Club, in partnership with Boulder Community Health and BNA, Boulder Neurological Association, is proud to help support our organization with a helmet grant this season, getting our athletes in the safest helmets so they can perform at the highest levels, but also provide an educational and lecture series for parents and athletes and coaches to make sure everyone's on the same page when it comes to important things such as TBI, which is traumatic brain injury, concussions, prevention and awareness, and things like that. Right now, athletes of all levels are skiing and riding faster than they ever have before. Up at Eldora, it's not uncommon for athletes to be going 50 or 60 miles an hour in training courses, in and out of the courses actually, on the mountain. Speeds, technology, equipment, everything is reaching the highest speeds we've seen, and it's only going to be getting that much faster. That's the reason of the lecture for tonight, is we want to get parents on the same page that when a crash does happen and there's an impact to the head, we want you to be able to know what those signs are, how to react properly, know what your resources are, and know what the proper steps are. Again, diagnosis, proper care, return to play, multiple successive concussions, and what to expect as parents and athletes is important to keep everyone on the same page. We'll have some time for questions at the end of tonight's lecture. Also, I'd like to say a special thank you to Francis and Kimber, who helped put on tonight's event. They've been instrumental in putting together this lecture for our organization. And at this time, I have a few more things to say here. I'd like to introduce our esteemed speaker this evening, Dr. Mason from Boulder Neurological Association. Dr. Mason's continued dedication to excellence in the field of TBI, traumatic brain injury, care, technique, and prevention. He'll be addressing different slides tonight that'll help us have a better understanding of what this is all about as it relates to concussion awareness. Quick bio on Dr. Mason. He received his medical degree from Ohio State University College of Medicine in Cleveland, Ohio, or in Public Health in Columbus, Ohio. He went on to complete his neurological residency at Cleveland Clinic in Cleveland, Ohio, with interest in neurological oncology, complex and minimally invasive spine surgery. After completing his residency, he completed a formal fellowship in, well, that's a big one, skull and base neurological oncological surgery at Emory University in Atlanta, Georgia. It's a mouthful. Please help me welcome aboard Dr. Mason.
Thanks a lot, Matt. So what we're going to do is spend the next 35 to 45 minutes just going through and talking a bit about concussion. I'll try to drive home some really straightforward points. When we get done tonight, you're not going to be experts in concussion, but I think you'll have hopefully a better appreciation and understanding of concussion and some of the mechanisms and problems that we're facing. I think some of the age-old teachings probably need to be rethought, and that's probably one of the take-home messages that I want you all to try to get out of. I'm also going to emphasize the importance of repeat concussions and why patients or athletes who have repeat concussions are more susceptible to more concussions, okay? And why occasionally, sometimes we need to pick different activities if you're susceptible to them and things like that. So we'll talk a lot about that. There's a lot of examples. As a neurosurgeon, I do brain surgery on patients who have very severe concussions and head injuries. Okay. We also take care of lots of patients who don't need surgery, thankfully, but who have significant problems with concussion and brain injury. I don't know if you guys know Kevin Pierce at all, but Kevin had a problem from a concussion that he then returned to play, if you will, and then had a second concussion while he was still recovering from that first concussion. And while one can always argue, oh boy, that second concussion was much more severe than the first, and that's why he had a problem, most of us that are experts in this particular field will argue that even the exact same concussion that's sustained at a period of time when your brain is still recovering from a concussion is almost always more severe. And I'll even talk to you about a very rare syndrome where those second concussions can even be lethal. Okay. Who here has had a concussion? Okay. Who's ever known somebody to die from a head injury? Okay. So we really have to think about that on a spectrum, right? let's go with the concept of concussion to head injury to a lethal head injury. And it's all on that same spectrum, right? And as a point of kind of basic education, our brain is pretty well designed, right? We've got this really hard helmet that's built in called the skull, and our brain floats in it. It's truly floating in basically a bath of fluid. And that does really well for minor injuries, right? But then as soon as we stress that system just a little too much or a little too far, we start to damage the brain, okay? Sometimes that damage can be imperceptible in terms of just even you and I talking, or it can be moderate. You can bruise the brain and have cognitive problems from that, or you can get it even more severe. And so there's a real spectrum. And so Kevin will never be the same. He's recovered from this. But he says one of the silliest things he ever did was go back and re-engage in an activity when he was still recovering from it first. And he recognizes that now.
And how is he today?
I don't know. Who asked that question? I've only seen a YouTube video from a while ago, so I imagine he's back at playing. I don't think he competes professionally or anything like that. Is anything else? The traumatic brain injury is a fairly significant issue in the United States. 52,000 deaths on average from traumatic brain injury. But let's look at the pyramid here. I mean, look at all these emergency department visits and the hospitalization. So we talk about deaths and things we don't want to talk about, but think about all the expense and the inconvenience here, and also the recovery that goes involved. And how about the even greater number of people who actually don't even recognize and or receive care from that? Okay? Traumatic brain injury is a leading cause of death and disability from age 1 to 44. That's pretty impressive. We're talking about Ebola. It's made a lot of press, right? Ebola would be like one line over here, right? Multiple sclerosis, you may have heard of that. Spinal cord injuries, HIV and AIDS, breast cancer, very popular, and very prominent. Traumatic brain injuries, 1.5 million. That's a big number. And so we have to put that on the spectrum. Remember, that can include the quote-unquote mild concussion. In a couple slides from here, I'll tell you that there is no such thing as a mild concussion. I'll tell you why I think that is in a second. And really, it's very important to know that the severity of a concussion really isn't known until that patient's recovered. So that you and I can be in, let's say we're riding a tandem bike together, and we go do an end over on a tandem bike, which would be a trip in and of itself. So in other words, we sustain the same injury. You might just walk away from it, no problem, and have no issues at all. Whereas I, having the exact same mechanism of injury, can really have significant issues and post-concussive type syndrome and symptoms for many weeks or months or sometimes even longer than that. And so everyone responds differently. And that kind of gets back to that basic substances as we talked about, the hard skull and that brain. Everyone's going to be a little different there. But then also the biochemical reactions that actually occur in the brain after a concussion. And that's where we're really starting to appreciate. This isn't necessarily a physical event. This is a biochemical event, okay? And a metabolic event, okay? And so that's what we're really trying to appreciate. Concussion is unique in that it carries a high risk of recurrent concussion and subsequent illness if not properly treated. Okay, that's very important. That's why evaluation is very important. Long-term dysfunction, especially cognitive dysfunction, emotional dysfunction can occur. Major health problems with no proven acute treatment. In other words, patients can have a concussion, we can provide supportive care, but it's not like when we break an arm, we reset the arm and put it in a cast, and we're good to go, right? That heals up. Brains are different than that. They're much more subtle. And there are multiple criteria guidelines, and each club, each school, each physician that treats concussions has different return to play guidelines, and there isn't an accepted one or a non-accepted one. But there are a couple of important ones. As we talked about some specific traumatic brain injuries in sports, cycling, we were just talking about that a second ago. Cycling is a very, very prominent one, and that makes a lot of sense. There's typically a lot of energy involved in cycling, and the accidents, obviously, because of the speed and as well as the energy, can be significant. There's also a lot more cyclists in this country than there are folks like winter sports, okay? But winter sports, that's a big number if you look at the number of winter sports that are out there, okay? And obviously there's lots of other potential issues here. And boy, we can go through each one of these and think about patients and potential mechanisms and injuries. But I think recognition that all sports can cause some of this. Some of the older definitions of concussion I think are important and need to be emphasized. We used to think it's kind of a reversible injury to the brain due to traumatic forces resulting in amnesia, okay, and or loss of consciousness. And then we kind of started saying, well, really it's just any alteration of mental function following a blow to the head that may or may not result in a loss of consciousness. Okay. Well, what we really realized is that you don't have to have been unconscious to have a concussion. You don't have to even have a direct blow to your head. Okay. Our skull is welded nicely onto the top of our neck, and so you can imagine any significant impact to our body can actually cause a concussion. You don't need to have amnesia to have a concussion. So these are debunking some of those old myths. You do have to have some concussion-related symptoms, even if you have a significant mechanism of injury, just like our discussion a second ago about the tandem bicycle accident. Just because you've got a mechanism of injury doesn't guarantee you can have a concussion. If a skier has a bad ski accident, they don't have to have a concussion. Okay, that's an important thing to emphasize. So you have to have some symptoms. But sometimes those symptoms are subtle, and sometimes those symptoms can be delayed. Okay? You can have normal imaging of the brain, x-rays, CT or MRI. And you may or may not have post-concussive symptoms, and we'll talk a little bit more about that. A few more thoughts or comments on definitions. And the reason this is kind of peculiar is if you give me the definition of concussion on a computer, you get a couple million hits. If you went to 10 different dictionaries, you get 10 different complete answers. You ask 10 different doctors, you get 11 different opinions about what concussions are. And so there's a lot of different potential definitions, but these are, I think, important ones to think about. You don't have to be knocked out. You don't have to have a direct hit. You don't have to be amnestic, okay? What we do know is that it's a complex process affecting the brain. It can be structural or not. And there's a disturbance in the brain metabolism. That's really important. These are 2 MRIs. Okay, it's a very specialized type of MRI called the diffusion tensor weighted imaging study. And what that basically does is it looks at the different pathways that the electrical wires are going in your brain. Okay, and suffice it to say that are these the same? No, they're not. Right. And so as you look at them, this has got more blue and less yellow, right? This has got more yellows and a bit more reds maybe than this, right? This is a normal brain, okay? This is a concussed brain in an asymptomatic patient, a patient who didn't have or doesn't have any symptoms, okay? Now, they developed some headaches about 2 days after that, and that's why they got this study. And they showed that even with just some mild headaches 2 days after the injury, what we found here is that there's some slowing of the pathways, the neuronal pathways, the nerve conduction pathways of the brain, okay? So that tells us that even with mild symptoms, we can have profound, by the way, diffuse changes in the brain with concussion. So that's why our pitch to you, if you had to have a take-home point, is take concussion seriously. Because even with very mild symptoms, you can have really significant. This is the right half of the brain. This is the left half of the brain. This is the connection between the brains. This is the brainstem. There are symptoms. There are signs of metabolic dysfunction all throughout the brain in a fairly mildly concussed patient. So what happens to the brain? Well, as I just said, there's metabolic abnormalities. To dive a little bit deeper, basically what happens is there are neurotransmitters, which is kind of like a positive charge or a negative charge, or in this case, a positive chemical and a negative chemical, that can sometimes cause a loss of autoregulation. It causes some glitches, if you will. You guys have played video games or used computers or phones enough to know what a glitch is, right? It causes some glitches. Sometimes a glitch on your phone is mild, right? No big deal. Sometimes a glitch is big enough you have to shut it back down and restart it. We can't shut our brains back down, can we? So we have to deal with that glitch and try to figure it out. There's also some decrease in changes in blood flow, where there result in energy crisis. What that really means, if you've got enough of a concussion, is that you can actually starve different parts of your brain. And that's a problem, okay? Recovering brains require a little bit more blood to make it better. That's why your ankle swells when you sprain your ankle. Same reason, right? It needs more blood, helps it heal, right? And so that's exactly the same issue. It can lead to brain injury, which can be temporary or can be permanent. Most often, thankfully, as we know, concussions are temporary problems. But if we don't treat them right or recognize them right, they can actually evolve into permanent issues. And then there are post-traumatic abnormalities and energy crisis that can last, basically the symptoms of this can last from days to weeks to months. It's one of the most common questions we have on a patient or a family member who comes into the office is, well, how long am I going to have these symptoms? Which we're going to talk about in a couple slides. And the symptoms, well, you kind of scratch your head and you look like idiots. You're like, well, I don't know. Everyone's different, you know? Depends on what part of the tandem bike you're on, what part of the ski slope you're on, how you're made up genetically, okay? So maybe this is a little bit too much detail, but let me just bear with me for just a moment. As we look at this graph here, what we see is that in a concussed brain, there's a mismatch. What does a mismatch mean? It means there's a higher demand for something that the brain can actually provide. So in this case, there is a higher need for oxygen and blood than the brain can provide because it's kind of messed up. It's glitching, as we just said. But here's what's interesting. This is days. We don't get back to normal on the average, in the average scenario for a metabolic abnormality for almost a week or more. On average. Everyone can be different, right? But that's a significant issue. And this period of vulnerability, where if we have a second injury, it can click even more. Okay? And so we can take a small mismatch, which we can recover from, and make it a bigger mismatch, which we might not be able to recover from. Does that kind of make sense? Okay. So, we talked about the fact that we see a lot of sports-related injuries, and the fact that, you know, if you're doing a contact sport, you can have as much as 19%, in other words, 1 out of 5 players can have a concussion. If we pull high school and college contact players, a third of them have had a concussion, which is a little bit, our room is a little skewed from what we do, right? But, you know, it was about a third to a half. 20% have endured multiple concussions though, okay? That's a big number. That's a big number. 1 out of 5 have endured multiple concussions. And the risk of concussion in football, which is a fairly significant contact sport, is 3 to 6 times higher in patients who've had a previous concussion, okay? And that kind of gets to the fact, and so why is that? Well, there's 3 reasons why somebody who has a concussion, whether you're a football player, a skier, a water skier, or a skateboarder, or what have you. There's 3 good reasons why somebody who's had a concussion is more likely to have another. First of all, maybe that's just how you are. Maybe you're just a more intense person. Maybe you have a little bit faster RPM. Maybe you just go a little faster. Okay, number 1. Number 2, we know for a fact that patients who've had 1 concussion are more susceptible to other concussions. All right. Get back to that kind of complex metabolic stuff that we were talking about. Well, that's kind of what we're talking about. The fact that we cause a little bit of derangement, and then all of a sudden we have another impact, hopefully after the time you've already healed, but that can cause a more serious derangement or a more serious glitch. Okay? And so you're more susceptible to the glitches that we just talked about. The third reason is that there's a genetic susceptibility, folks. This is what people hate to hear in the office, so I'm glad I can talk to you about it here. There's a genetic susceptibility. There are some athletes that are more susceptible than others. Maybe it's because of factor 1 and factor 2 that we just talked about, but we're coming to find that there's actually a true genetic susceptibility. I can't draw your blood and figure out why you didn't get a concussion and I did from our tandem bike accident at this point, but there is a genetic susceptibility. And those are the players that sometimes concuss out of sports, and that's always a bummer for a lot of reasons. Doesn't surprise anybody in the room. Ice hockey's got one of the highest incidences. Skiing, 1 for 1,000 visitor exposure. This is probably what we consider recreational skiers. So again, folks in this group who are doing more high energy, high impact skiing are going to have a higher number here. Snowboarding actually has got a really significantly increased rate of concussion. Now, one of the interesting things we are finding with our data at this point is that our data right now spans the pre-helmet generation to the post-helmet generation. Everyone in the room, I think, just looking at your general ages, can remember all of us riding down the hill without even thinking twice about a helmet. And so our data is a little dated at this point, to be honest with you. Okay, we know for a fact that when we go out of the slopes, what would you say? 3/4 of the folks on the slope, generally recreational skiers, have helmets on. At least.
More.
Higher. 90%. Okay. And I remember when it was 0. So you guys. So that's part of a problem with our data on injuries, with head injuries, with that kind of stuff. So there's a bit of a dilemma, though. We talked about the dilemma of definition, right? About the fact that, oh boy, we don't really know how to define it. All we know is that it's not what we used to think it was. You don't have to get knocked out. You don't have to be amnestic. You don't even have to get your head knocked to have a concussion. So we just really broadened the ability to get a concussion. So let's add to the complexity of the problem. And that is that a physical exam and an assessment is really inadequate to identify problems. In other words, I as a physician who's an expert in concussion can't go up to you and examine you and say, oh, you've got a concussion. Now, over the course of a week or two, I can. And sometimes it's a no-brainer. But a lot of times it's not. Okay? And it's those subtle, more mild concussions. I just said there's no such thing as a mild concussion. So that's why I'm putting it in quotes. But a milder concussion it's going to be a more difficult thing to assess. And sometimes it takes multiple data points, multiple office visits, or frankly, just a little bit of time under our belt. If you knock your head and you're doing great after 15 minutes and you don't have an issue, fine, you didn't have a concussion. Okay? If you're still having symptoms 1 hour later, 2 days later, 1 week later, you bet you do. So, loss of consciousness and the length of consciousness does not correlate well with concussion outcomes. Increase in tension on post-concussive symptoms. Again, that was that classic example where 2 days after a patient gets a concussion, they start developing a headache. We're like, why? Well, they actually had a concussion, okay? And that's why sometimes you can't assess it right on the sideline, and that's the challenge. We all want to get back to sports. We all want to return to play yesterday. I want to get back into the action, right? And that's where sometimes we have to use our heads, no pun intended, and say, maybe I should just sit this one out, And it's a little frustrating. Ski passes are expensive. Forced use of injured brain can worsen outcome. We know this. So if we go back to the usual, back to the norm of a brain that's been concussed, go back to work, go back to school, go back to your activities. Besides the fact that you're at increased risk of concussion, you can also actually cause your injury to have longer symptoms. So I'd rather just kind of get over my concussion and be done with it, okay? In other words, maybe take the rest of the day off or take the next hour off and kind of get a sense of things. Go to lunch or whatever it takes. But we don't have great hillside. We don't have great sideline. We don't have great assessment tools to really get a good sense of the best way to assess a patient who's got a concussion. The really best way to do it is to use your head and look at how bad the accident was and how bad the severity was. That's number one. Number two, have somebody else who isn't a biased person look at you. If my 9-year-old gets whacked in the head with a stick, I'm the worst dad in the world, right? I'm like, okay, you are fine, go back to play, whatever. But I'm the wrong person to do that. I should have my next door neighbor do it and say, can you look at Jack and tell me what you think, see how he is? And I say, yeah, looks like a perfect normal kid, or actually, no, he's a little slow, So having non-biased observers is important. Coaches, honestly, and I'm a coach of a team, we're not great. We're not great. Parents, we're not great. We want our kids to enjoy playing and get back to playing. They were doing so well. They had this close thing. They had a great run. They did this. They did that. Sometimes that's not either. We're giving you all kinds of dilemmas here, right? We're confused about our definition. We have some ideas. We've just told you that the therapeutic dilemma is real. In other words, we have a hard time assessing it. So what do? Well, we look at some things. We look at things like symptoms. Prolonged headache. Visual disturbances, blurriness. Double vision is a big one. Dizziness, nausea, vomiting. Boy, if you've got that and you don't think you've got a concussion, come and talk to me. Impaired balance, ringing in ears, light sensitivity. Okay. Who's ever had a migraine? A lot of these are kind of migrainous types of symptoms, aren't they? Some of them are, right? Emotional. Now, you're not necessarily going to see somebody who's going to be emotional hillside or sideline necessarily. But these are some things that you can actually see fairly quickly on. Cognitive impairment. Obviously loss of consciousness. Slow reaction times. This is one of the key ones that we're really looking at from a research perspective to see, because this is something that's repeatable. It's easy to test. It takes away the bias. Confusion, obviously. Difficult to concentrate, feeling like you're in a fog. You give these people a test, and you have that. And we're doing this with football players. A group that I work with is doing this with football players, and it's amazing the differences on these tests in terms of the reaction times, number one, and number two, the concentration times. Now, smart lines, bombing right away. They purposely score much lower, much lower than we want to, so that if they get a concussion, then they're back down to where they are. So we're working on some ways around that. Brilliant, really. Amnesia, sleep disturbances, and emotional. These are things that are kind of delayed, right? I'm just not sleeping right. Maybe it's altitude. Probably not. Drowsiness, behavioral changes, irritability. These are the kinds of things that we see later, okay? These are the things we see right away. These are some more subtle things that you can or can't see. Okay. Headaches is kind of a no-brainer. Visual disturbances. I like emotional, I like sleep disturbances, I like behavioral disturbances. As parents and coaches, those are the kinds of questions you can be asking too. How'd you sleep last night? I didn't sleep well at all. Why not? I don't know. I usually sleep hurt. Red flags. We talk about red flags in neurosurgery because red flags are things that we get freaked out about. And it takes a lot to get us freaked out, but we get freaked out about things like this. Prolonged loss of consciousness, 3 to 5 minutes or longer. Okay. A seizure, obviously. Now, little kids can have seizures pretty easily, less than 5 years old. Still needs evaluation. Neck pain associated with this, always a big deal. Okay. Focal neurological signs, what does that mean? That means they can't move their arm or their other arm or their foot or their one eye's goofy or something like that. A focused problem. Okay. Progressive worsening symptoms. As coaches and parents, we talked about the most typical scenario, which is a mild head bump, right? If you're on the fence, have them sit out for 15 minutes or 1 hour. Reassess them 3 times. Get multiple data points. You guys are smart. If you see a trend in the wrong direction, wait a minute, he just got this right an hour ago. How are they not answering these questions right now? Or my gosh, they seem more drowsy than they were before, those kinds of things. Repeated injuries, whether you're in Tanzania, on the hillside in Eldora, or somewhere else. Repeated assessments, even parental assessments or coach assessments are perfectly great. Progressive worsening symptoms is a huge problem. So these are red flags. These are things you guys need to get help for and be evaluated for anyway. Common question, is an MRI or a CAT scan of the brain necessary? A lot of times people come in because they want that. And honestly, not usually. You know, if we see some of these red flags things, you bet always. But usually we don't see those, thankfully. And so usually we don't actually, it doesn't really add any benefit. It's a normal MRI, a normal CAT scan. It's not going to change our management. Our management really has to do with dealing with the symptoms and kind of talking about this graduated return to play, which we will talk about. You know, I say potential tools for the future, but I would actually just say tools we're looking at kind of now, you know, in terms of really reaction time testing. There's a couple programs that are out. The University of Colorado uses a reaction time testing program as well. Genetic testing, I kind of hinted at this earlier, but this is a very important thing. We're not at mainstream on genetic testing, but in 5 years we will be. In 5 years you can have your blood drawn and see if you're more susceptible to concussions. Okay. Other potential markers, and I'll show you a picture of this in a second. These are different proteins in the brain that get deposited that sometimes in some people can be on this. And I'll talk about that in a second. So we talked about the fact that you can bonk your head, that you can have a moderate concussion or a severe concussion or a trivial concussion. And we talked about the main problem with most concussions isn't a structural problem. It's a metabolic problem. It's the glitching, right? It's the glitching. These are some problems this is when I get involved more acutely, and that's conditions that go along with concussions. This is brain bleeding, okay? This is a skull. See how thick that skull is? 3/4 of an inch thick. It's pretty tough. Here's the brain itself here, okay? This white stuff right here is blood. You see how it's smushing over the brain over here? This guy has got a red flag, okay? This patient's got red flags. This patient's got red flags. This patient probably not doing as well. But there's a big little glob of blood pushing that brain over, okay? We talk about helmet and helmet awareness. We don't see this as much as we used to, partly because of helmets. These bad brain bleeds. We do see them sometimes, but not always. So, skull fracture, hemorrhages, swelling, seizures, migraine headaches. Migraine headaches after concussion is something that is a challenge. Close your eyes. Brain. This is a normal brain here. This is a big blood clot on the surface of our brain here. This is an autopsy specimen. If that helps. Here's a normal surface of the brain. Our brain's covered and floating in the Ziploc bag. Inside the Ziploc bag is fluid, and then the brain sits and floats in the fluid. That Ziploc bag looks like this, and if it's enough pressure, it can cause some real pinching of the brain that way. So we can have other problems. We call those structural problems. Those are thankfully far less frequent. But as we talk about red flags, those are the things we'll work with. Let's talk about post-concussive symptoms. Post-concussive symptoms are symptoms that occur after the initial effects of the concussion have gone away. There's no longer visual changes necessarily. They're fine, they feel good, maybe a little bit of residual headache. They feel like they can go back and play. But then you start asking, and they're like, well, I still get headaches every day. I never used to get headaches. I've got real fatigue, okay? Dizziness, irritability, as I said, and sleep disturbances are really good ones to talk about. Difficulty concentrating, memory problems, low tolerance for stress, emotion, or alcohol. Things to really think about from a parenting perspective, from a coaching perspective, okay? Post-concussive symptoms really means you need to back off in your activity, both intellectual activity as well as sports activities until these symptoms resolve. They usually do. Usually within 6 weeks, sometimes longer. Okay? Headache, fatigue, dizziness, irritability, sleep disturbance, difficulty concentrating, memory problems, and low tolerance for some of the things of daily life. I'm going to briefly bring up second impact syndrome because it scares us. It's very infrequent. Less than 2 people die a year from it. But it usually makes the sports. It's usually with a football player. Sometimes it's with a skier. They had a hit in the first quarter. Totally back to normal. Very mild concussion. They go back in, get another hit in the fourth quarter, for example, and they have uncontrolled brain swelling, which leads to problems and usually death. Okay. It's very rare, but it's something that one of the reasons that we get really upset about patients who are not completely normal and go back to play. One is that first example we talked about Pierce, who had that second impact while he was recovering from his first concussion. The second one is because of the second impact syndrome, which can be lethal. Okay. Most are reported in adolescent athletes. Okay. And the second blow can be remarkably minor. But the good thing to think about, or the way to think about this, is again that glitch. If you've got a glitch and then you throw another glitch on top of it, if it's timed just right, if you want to think about it like that, that can cause the problem. Okay. And so it's basically one glitch on top of the other, if you want to think about it. So it's why it's so very, very important to really make sure that our athletes, our friends, our family members are as neurologically okay as possible. I'm just going to bring this up because I think it kind of rounds out the discussion. It's less apropos now because a lot of us know about this. This is the classic end-stage example of what happens when you have repeated head injuries or head injuries upon head injuries. Okay? And Muhammad Ali is a great example of it. And it's basically multiple repeated head injuries over time, which basically causes parts of your brain to die. Okay? And symptoms don't need to be discussed, but memory loss, confusion, impaired judgment, paranoia, all these kinds of things. Progressive dementia is this abnormal. Okay? And it's very common in boxers. We see it with some frequency. Here's an interesting picture. Here's a healthy brain. It's a cut of a healthy brain. This is probably 3 inches or 2.5 inches. And this is stained with a particular kind of stain that identifies and shows a scar on the brain. Okay? A football player we'll call this an NFL player. This isn't a high school player. An NFL player. Okay? There's been a lot of press. There's been a big lawsuit about this. They can have a real significant scarring in the brain. Boxers can have really big scars in the brains. These are the guys that develop that chronic traumatic encephalopathy. This is why we want to avoid those repeated concussions. Okay? Why we really want to counsel our family, friends, and loved ones to think twice if they've had repeated concussions. Maybe there's a genetic profile that has more concussions than normal. Maybe they just play too hard. So what do? We think we understand how concussions occur. We think we understand that it's a kind of a glitching process. We've also talked about the fact that you can get some structural abnormalities. We talked about a bunch of symptoms that are associated with it. We also talked about post-concussive symptoms, which are the symptoms you can get after the initial symptoms go away, right? Talked about all that stuff so far. So how do we manage it? Well, first of all, we want to rule out the red flags. We want to rule out more serious problems. We call this more serious intracranial pathology. This is doctor talk for bad problems. So we want to prevent that second impact syndrome. In other words, we don't want to jump back into play while we're still recovering from that first one. We want to prevent repeat injury during a post-concussion period of vulnerability. We called it 7 days. I'll get you another chart that even suggests that it goes a little bit longer than that. We want to make sure that we prevent against cumulative effects of injuries. In other words, we want to prevent the fact that if somebody's got some symptoms, that they don't necessarily engage in other stuff. And that's what we're going to talk about in a second with the return to play. Thankfully, a majority of injuries will recover spontaneously. It's great. That's what we want. That's what we usually see, right? But we're all here in this room because we want to learn a little bit more about concussion and about the severity of concussion. Physical and cognitive rest are required while patients still have symptoms. If a patient doesn't have symptoms after a head injury, their concussion is resolved for the most part. Not always, but almost always. Okay? I like 7 days a lot. So this is interesting for 2 reasons. This is taken from a cognitive skills test, which isn't the best test, but it's not a bad test. And as we look at athletes, which are in red, or blue athletes, which have had no previous concussions, pretty significant issues up until week 4 or week 5. Now, most of us would argue and say, wait a minute, I've had concussions before. It did not take me 5 weeks to get over that. And I agree with that. Okay. But let's say what's really interesting about this particular cognitive test that they administered wasn't that. It's the patients who've had 1 or more previous concussions. They are much slower, not much slower, but statistically different in terms of slower on their recovery. Okay? And so that's why it's so very important in patients who've had previous concussions to make sure that they're well. Make sure they've completely recovered before returning them to play. All right? So, returning to daily activities, we usually recommend a gradual return to your daily activities. If the symptoms worsen or return, lessen the activities. Returning to school. Usually we recommend that the school personnel, their teachers, maybe they bring a note, however the school system does it, and they need to be basically, and all schools in the area have concussion protocols, by the way. They need to be watching for, and you as parents and coaches need to be watching for attention, concentration, remembering information, irritability, how are they doing socially? Maybe some shortened classes, especially for moderate or severe head injuries, okay? Sometimes people really need to get back into their work or their job or their school environment, things like that. I think it's super important. But at the same time, we want to make sure that, that we're doing that in a graded fashion. Returning to sports. It's super important not to return to sports if you have any symptoms. And my general rule of thumb, and it's a conservative rule, as a neurosurgeon who knows probably more about this than most people in this room, but maybe not, is that I don't let people return to sports until they've been symptom-free for 7 days. Okay? So the day you say, I no longer have a headache, I feel normal, then I suggest waiting 7 more days and then returning to practice. So, gradual return to play. This is kind of the gradation of kind of how we think about it. Everyone's a little different in terms of how this works. Okay? Some people like to say, let's do this over 4 weeks. Some people let's say, do this over 5 days. Okay? My job isn't to tell you what the right or the wrong, because we don't know what it is. But usually a week or 2 is what I usually think about when I talk about people who have had moderate head injuries, who are now asymptomatic, they have no symptoms of the things we talked about, they're otherwise doing well, they want to go back. No physical activity is level 1. And then low levels of physical activity such as walking, light jogging, stationary biking, weightlifting. And what you're looking for here is, do they have return of the symptoms? If they don't have return of the symptoms, then we're good. Then we're rolling. Things are working again. Moderate levels of physical activity, okay? Moderate jogging, brief running, whatever. Jogging, running. Who jogs? Don't we run? Again, moderate. Low, moderate. And then heavy but non-physical contact. We really want to minimize the chances of having a repeat head injury in this acute period, okay? Full contact and control practice, full contact in game. My ideal thing is 2 to 4 weeks on this. Some people really escalate this, and it depends on the degree of the injury. Again, going back to the tandem bike thing. I might have to have 4-week roll-up on this. He's going to be back 3 days later, no problem, okay? 2 weeks is fine. What we do know is and again, I'm preaching to the choir here, but encouraging the recognition of concussion and reporting of those concussive symptoms. Okay, we're going to talk a little bit about some studies, and again, who said that it was 90% or 90+%? Somebody, whatever. Obviously, that's true. There's no real debate on it, but there's actually some interesting data that I dug up about the fact that it does show that helmets do help. They decrease morbidity. Now, I've actually talked to some people who say, well, wait a minute, they may help with the head, but they actually increase neck injuries, right? It's a heavier helmet, you know, these helmets are 3 to 5 pounds, 8 pounds, whatever, GoPro 9 pounds, you know, boy, is there a real problem. Well, what we've shown on several good studies now is that and we call this the helmet debate, is that they really do help. There's a significant reduction of injuries with using helmets as compared to not using helmets. And snowboarders are at a higher risk when compared to skiers. I don't know why that is. I think I know why that is. What do you guys think that is?
They can't pop out.
Can't pop out, number 1. Number 2, they probably do more tricks, right? A lot of skiers are going down groomed or not so groomed. Snowboarders oftentimes will be in parks and things like that and have a higher frequency of collisions with other people or inanimate objects that don't move as well. 2010, we showed helmets really reduce the risk of head injury among skiers and snowboarders with no evidence of increased neck injury. So if anybody ever gripes to you about the fact, well, I'm more concerned about my neck injury, say, well, when you drive in your car and you've got a seatbelt on, sure, you can get into a car wreck and the car can burst into flames and you might have that problem. But it's far less likely to have that problem than to have benefited from the seatbelt. Okay. Again, I'm beating a dead horse here, but this is, again, older data, as we talked about, we're bridging the data. But I think importantly, increased awareness and reporting is super important. You want to talk about helmets?
Sure.
Why don't you jump in on that? I've only got one or two more slides after that.
And do you want to talk to these slides first? Then I'll
Sure.
go ahead.
I think the important thing that I'd really like to emphasize to the kids that we talk about, we have a different presentation that we give little kids that we're working on. And the key thing on that is that helmets don't make you invincible. It's amazing. kids really think sometimes that helmets really make you invincible, and they're just not. And that needs to be really driven home. They help protect you, but I really equate it when I'm talking to kids. It's like wearing a seatbelt. Does a seatbelt protect you with everything? No. Does it help? Yes. And so that's it. Traumatic brain injuries affect more patients than all other neurological conditions combined. It's very important. It's all about recognition. Obviously, the best treatment is prevention. We talked about very important signs, symptoms, and recognition, as well as kind of the concept of graduated return to play. Neurosurgeons are certainly amongst the experts in this field, but there's a large number of people that play in this space, and I think that we need to recognize that. Why don't you jump into helmets, and then we'll jump into questions and talk a little more about it. Does that sound good?
Great, thank you. Real quick, I think we're all familiar with the helmets that are required for alpine ski racing, but just some quick review points. Athletes are required to have a hard ear helmet that covers the ear for alpine GS and slalom racing. As they get older in the sport and they start racing at fist level, they can use what's called a soft-eared helmet. Sometimes you'll see the older athletes utilizing that. U14, U16 and up, it's a recommendation that they have a fist-approved helmet. But if it's a recommendation, obviously next year it's going to be required. If it's a recommendation this year, you might as well move into that helmet if you have that opportunity. There's been some technological advances in the helmets that are now fist-approved with greater shell protection on the front of the helmet for the gates impact or for front impacts when the athletes crash as well. Also, one thing that we as a club recommend is that the face guards athletes use for slalom, they look cool, the kids love wearing them. We only ask that they wear them during gate training. When they're out free skiing or working on drills outside the course or on the mountain, to take that face guard off, because in the case of an impact, face first into the snow, that face guard can actually work as a levering mechanism and twist the neck and then cause an injury to the neck as well. So kids are pretty good about taking those off, and the lodge coaches as screwdrivers, they can help take those off, things like that. But just remember, take them off when they're not inside the gates and training right there as well. Through our helmet grant, athletes have the opportunity to go to Alpine Base and Edge and choose from a variety of helmets. Whether you're a younger athlete and you don't need the FIST required helmet, or you're an older athlete looking to get support at the FIST level with a helmet, we want to be able to provide athletes with the safest helmets as possible. In the event of a concussion that your athlete sustains, a lot of parents will ask the question, do I need to replace the helmet? Well, if it was a serious enough head injury to sustain a concussion, and we don't know what level or degree of concussion that is, I would recommend a helmet replacement. Depends on what the events were. Sometimes in a speed event, an athlete can have a high-speed impact in a Super G or downhill, but then again, in a slalom course, an athlete that flips 360 and slams their head backwards onto the hard deck on the snow can have just as severe as a concussion as someone in a speed event. So something to think about with that.